We have a Dr. Mike video, non-political. Ooh.
Dr. Fong has taken the social media world by storm, igniting passionate discussion surrounding calories and their value when it comes to weight loss. His belief is that insulin and other hormones are more impactful than calories when it comes to weight management. Today, I wanted to directly discuss some of these hotly contested statements and find some common ground in this highly complex and often heated nutrition space. Turns out, it's way more complicated than I thought. So for the very first time, I'm trying a new truth-seeking approach where upon a significant point of disagreement during the conversation, you will hear this sound. And that is to signal to you that there's a footnote in the description of this video leading to a separate short video clearing up the controversy with sources. Get ready for a deep dive on the science of nutrition, weight loss, and reversing chronic disease. Let's get started. Dr. Fung, I'm really excited to talk with you on a topic that very much needs more attention, the topic of obesity. As you've said in previous conversations, I mean, we've had guests talking about it. We're in a crisis state. We're 60, maybe now 70% overweight or obese as a nation here, at least in the United States. I'm assuming similar figures in Canada? Or
a little less. But
a little bit less, but also climbing. And truly a worldwide issue, right? More pandemic than epidemic at this point.
What are these chairs? Somebody find me these chairs on Amazon.
I've heard your very strong interest in the topic, but you're a nephrologist, which is a kidney specialist and not necessarily the specialty that usually talks about obesity. How did you find that to be a topic that you were so passionate about?
Yeah, it sort of followed from type 2 diabetes. So what happened, from 1977 is that obesity went up. And about 10 years later, 12 years later, what you saw is a huge epidemic of type 2 diabetes, which is very closely related diseases. And so once you have the type 2 diabetes, you can develop kidney disease somewhere around 10 or 15 years into the diagnosis of type 2 diabetes. So as you get, 1977, you start to see this uptick in obesity. By 1990, you see uptick in type 2 diabetes. By 2000, 2002, when I'm getting out in practice, now you're starting to see diabetic nephropathy. Like,
oof. Okay, I don't know anything about this guy. Wait, I'm not disparaging this guy at all. I don't even know what he's going to talk about. One thing that's scary about diabetes, though, is anytime somebody starts talking about diabetes, this is like one of the fester grounds for some of the worst dieting and medical shit like ever said, where people have the craziest theories about fucking what is diabetes really. I don't know if that's a scare or not, but apparently that a lot of people in the chat were saying the book that this guy's written was really good. So
all over the place. And it's by far and away the biggest cause of kidney disease. So the two big ones really is type 2 diabetes and hypertension. So both of them are related in some way because they're very much metabolic diseases. They're related to weight and so on.
So, and to lifestyle.
And to lifestyle, exactly.
Right.
And the point was that around 2008, 2009, I realized that as a nephrologist, as a medical profession, we had been thinking about this completely the wrong way. So when people develop their type 2 diabetes, we give them medications such as insulin. They gain weight, but we didn't actually change the course of the disease. And that's in 2008, 2009, several very large trials, the Accord trial, the Advanced trial, and the VADT came out, all of it showed that if you control the sugars, the blood sugars, by giving lots of insulin, then you actually don't change the course of the organ damage. So you're not slowing down the kidney disease or heart disease or mortality in any significant way. And
I wouldn't have expected that at all. That's interesting. My assumption, without knowing anything, I would have assumed that kidneys were damaged by an elevation of, I guess, glucose in the blood, but maybe it's not. How does type 2 diabetes damage kidneys? Each kidney is made up of money over time. High blood sugar from diabetes. Oh, this does say, oh, interesting. I wonder why insulin doesn't help then. Many people with diabetes also develop high blood pressure. How does diabetes cause hypertension? Coexistence of diabetes and hypertension is known to have a multiplicative effect on Dr. Jason Fung. I wonder if he's on this paper at all. No, okay. On adverse clinical outcomes with respect to both microvascular and macrovascular disease, effective management of diabetes should therefore include a multivascular. The pathophysiology of hypertension in diabetes involves maladaptive changes in the autonomic nervous system. I don't know what autonomic nervous system is a component of the peripheral nervous system that regulates involuntary physiology processes, including heart rate, blood pressure, respiration. Okay. Vascular endothelial dysfunction. Endothelial dysfunction affects your endothelium. I don't know what this is either. Part of your heart or something? I don't know. your endothelium is a large organ that plays a key role in keeping your blood moving smoothly through your body. It's made up of over 1 trillion endothelial cells, which release substances aid in blood flow. It's a single layer of cells called endothelial cells, which line all of your blood vessels and your lymphatic vessels, including your arteries, veins, capillaries, and lymph capillaries. Okay. Thin layer of cells lines the inside of your blood vessels. Dysfunction means the cells don't work the way they should. Instead of keeping blood vessels open and dilated, the cells cause your blood vessels to constrict or narrow. The condition is caused by vasospasm, a type of coronary artery disease. This means your coronary arteries become narrow, even though there isn't a physical blockage. Endothelial dysfunction can also increase the risk of coronary heart. Okay, gotcha. Enhanced activation of the renin, angiotensin, aldosterone system. Okay, it fucks up a lot of shit. I think that's what I'm saying. Holy shit. It's a system of hormones, proteins, enzymes, and reactions that regulate your blood pressure and blood volume on a long-term basis. It regulates your blood pressure by increasing sodium, salt reabsorption, water reabsorption, and vascular tone, the degree to which your blood vessels constrict or narrow. Immune function alterations and harmful environmental factors. Okay, Jesus. Multiple high-quality randomized controlled trials have shown improvement in morbidity with lowering of elevated blood pressure in people with diabetes. Attention must be paid to individual risk factors and comorbidities with a goal of less than 130/80. So diabetes are at a higher risk of cardiovascular disease than those without diabetes. Good glycemic control, optimizing weight, and promotion of exercise, while listening harmful environmental factors such as air pollution, blah, 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 blah. Okay, all right, gotcha. Sorry, jeez.
And so it really didn't damage. So you're not slowing down the kidney disease or heart disease or mortality in any significant way. And so I really started...
Wait, are you saying by controlling sugar levels, blood sugar levels, you weren't controlling mortality and morbidity?
Oh, fuck. He's asking the question I just asked. Well, fuck me. Because that's what I would have assumed, right?
Rates?
Yeah. So we all learned, like I learned, so I went to school in medical school in the 1990s. So we all thought that the sugar in the blood was what's causing all the problems. The sugar in the blood causes glycation end products, which would cause atherosclerosis, which would cause heart disease, kidney disease, and the whole rest of it. So the idea was we should give people lots of insulin, get their blood sugars down. And so that was the trial, a big NIH trial, multi-center, randomized control trial, 3 different ones actually. And what they did was they looked at giving people lots of drugs to get their A1Cs down, which is a measure of the blood glucose. Mm-hmm. And sure enough, you could drop their A1C from about 8 to about 7, 6.5, something like that. Mm-hmm. But the thing was that that's not what they're interested in. We knew we could get that blood sugar down. What we wanted to know was whether we could slow down the heart disease or the kidney disease or the total deaths. Turns out it wasn't effective at all. So if your sugars were quite high and you didn't treat it, it was basically the same as if you did treat it, which was a huge, huge, shocking thing. So that this was the Accord study. In fact, those who got the insulin and the tight glucose control did worse. They died at a higher rate, which was completely opposite from what we thought the result of the trial was going to be. Mm. The problem was that people didn't change their practice after that, but I thought it was actually very striking because it wasn't one trial, it was 3 large randomized, multi-center randomized control trials that showed the same result.
That's so weird because right now, my guidance from the major organizations, the American Academy of Family Physicians, ADA, AHA, is controlling the hemoglobin A1C or the fasting glucose to a range will not necessarily solve all the problems because there's usually comorbidities happening at the same time, as you mentioned, high blood pressure, usually some lifestyle issues related to either obesity, poor sleep, all those factors. But controlling the blood sugar does yield better outcomes, even in the sense of you're preventing patients from ending up in DKA.
Yeah, the acute things for DKA for sure. But no, if you had an A1C of 8% versus 6.5%, no difference in mortality whatsoever. In fact, maybe, according to one of the studies, but not the other 2.
So lowering A1C might help with like diabetic neuropathy, but it's not going to help with your like, I don't think you can die from diabetic neuropathy, right? But things like lung disease, or not lung disease, heart disease or kidney disease are things that can kill you, and it doesn't help with that.
Maybe even a higher mortality. So in fact, a lot of the guidance.
Whoa, fact check. Uh-oh, he's dropping live fact checks on this guy. Uh-oh.
Maybe, according to one of the studies, but not the other 2, maybe even a higher mortality. So in fact, a lot of the guidance prior to 2008 was a target A1C of 6.5, actually. Mm-hmm. That all changed to about 7 to 8 is considered acceptable now. It didn't make a difference, and there's a good reason why, and it's because their understanding of type 2 diabetes was fairly...
Yeah, wait. So at the intro, did he say that anytime a fact check shows up, does that mean this guy was wrong on something that he'll come back with a thing on, or is he just posting sources to support what he's saying? Okay, now we're on.
Discuss some of these hotly contested statements. calories and their value when it comes to weight loss. His belief is that insulin and other hormones are more impactful than calories when it comes to weight management. Today, I wanted to directly discuss some of these hotly contested statements and find some common ground in this highly complex and often heated nutrition space. Turns out, it's way more complicated than I thought. So for the very first time, I'm trying a new truth-seeking approach where upon a significant point of disagreement during the conversation, you will hear this sound. And that is to signal to you that there's a footnote in the description of this video leading to a separate short video clearing up the controversy with sources. Get ready for a deep dive.
Okay, so fact check doesn't necessarily mean somebody's right or wrong. It's just going into the source deeper. Gotcha.
Their understanding of type 2 diabetes was fairly rudimentary. They didn't focus on the weight loss part of it. This is a thing that struck me as crazy. So at the time, of course, there were not the same number of medications. We treat people with insulin. And so what happens when you give people insulin, right? So you have a type 2 diabetic, their A1Cs are high, you give them insulin, what happens? They all gain weight, right? It's just universal. So patients would go out and give them.
Can we watch the explainer video? How long?
For my first fact
Oh, okay.
check here with Dr. Fong, I was quite shocked that he made the statement, if your sugars were quite high and you didn't treat it, it was basically the same as if you did treat it. That's not what that research showed. He actually even sent me the research, the advanced trial, the core trial. These were kind of landmark trials. These trials weren't created to figure out whether or not it was worth treating someone's elevated blood sugars in type 2 diabetes. We know we need to do that because on the flip side, if we don't treat someone's blood sugar and it gets completely out of control, that's life or death. So we know we have to treat.
Oh. No, wait, hold on. Yeah, wait. I'm trying to think. I'm thinking of diabetic neuropathy. If your blood sugar goes too low, you can have diabetic shock, which is considered your blood sugar is too low and then you could die, I think, right? But if your blood sugar gets too high, can that kill you acutely? What's like the worst thing that can happen? Hypoglycemia? Is that like a thing? Is hyper higher? Hyperglycemia? Stroke? Severe hyperglycemia can lead to acute, sudden, and severe life-threatening complications called diabetes-related ketoacidosis, especially in people with diabetes. Okay, so so severe hyperglycemia can kill you acutely in a very short, bad event. Okay.
What those studies set out to figure out was how strictly we need to control their blood sugar. How low do we need to push it as close to normal with medications? So it's not that if you didn't treat it, it was basically the same as if you did. It was, you definitely need to treat it, but do you need to treat it very aggressively and bring it almost as close to normal? Or do you treat it somewhere in the middle ground? And those.
Okay. So he might have overstated it a little bit, but it sounded like when he was giving an example, it sounded like he was saying like whether or not your A1C is like 8 to 7 or like 9 to 8 or something, it's not a huge difference. It didn't sound like he was saying you have like crazy A1C and you're okay. That's what I remember him saying. So maybe he was overselling that a little bit, but it sounds like he kind of had. Let me check. Oh, just play. Why are you doing this? Oh, nice. Thank you.
But controlling the blood sugar does yield better outcomes, even in the sense of you're preventing patients from ending up in DKA.
Yeah, the acute things for DKA for sure. But no, if you hadn't.
Oh, the DKA thing is what we just ketoacidosis or whatever.
A1C of 8% versus 6.5%.
Okay,
no difference in mortality whatsoever. In fact, maybe.
Yeah. Okay. So here's what he's saying here: 8% versus 6.5%. Yeah. Okay.
According to one of the studies, but not the other two, maybe even a higher mortality. So in fact, a lot of the guidance prior to 2008 was a target A1C of 6.5, actually. Mm-hmm. That all changed to about 7 to 8 is considered acceptable now.
Okay.
Studies answered was that you shouldn't treat it as aggressively, especially in very specific populations like those who are prone to hypoglycemia, low blood sugar, those who are elderly, those who have significant other morbidity, meaning other illnesses. So we needed to get a more accurate goal that needed to be individualized for each patient. I'm talking about their blood sugar goal. So it wasn't like we were treating patients for no reason. We were treating them. We just needed the research to figure out to what goal we should treat them to. He makes it sound in this section as if we were doing this for no reason and controlling people's sugars was a waste of time. That's absolutely not true. And you absolutely need to treat someone who has type 2 diabetes in order to prevent the complications that come with having elevated blood sugar. What's interesting is that he even says there was no improvements in kidney function, but the advanced study, for example, showed that intensive glucose control actually did create reduction in nephropathy, which is kidney damage. So like, There's so much nuance there, and making it seem like doctors were just willy-nilly treating patients with insulin doesn't seem honest in this regard, or at least accurate.
Jesus.
Because doctors were trying to lower people's sugars. We may have lowered them too low, but that was the purpose of doing the research, to figure out how low we should go. And when we say low, we mean how close to normal, as someone who doesn't have diabetes. He also says that after that research came out, there were no changes from the major organizations in terms of treatment of diabetes, and that's untrue. Looking back at it, the agencies, the ADA, the American Diabetes Association, and others did make changes in terms of creating individual target goals, usually around 7, so maybe...
Okay. Also, wait, somebody said they found this chair. Bro, no shot. $740 for 2 of these? No way. I want a chair like $200 each, $250 each tops, okay? $380 each. Fuck that. Hell no.
Not as strict as dropping people down to 6.5 or even lower than that, because we saw that tight glucose control create more side effects, more problems. That doesn't mean the treatment was the problem. It means our treatment goal was the problem. We just needed to adjust how much treatment we were giving. And this is an ever-evolving part of science, so I don't know why we would just judge that so critically. That's almost the same as judging people in the past for not realizing that there were bacteria on our skin.
How do you feel about this method of fact-checking? I think it's good. Fact-checking is always good.
And before they had microscopes and were able to identify it. It's not fair to judge those in the past until we had the data to back it up. Also pointing out that a lot of patients continued to gain weight while they were given insulin. Yeah, that was an absolutely unintended side effect, where people were not controlling their diets. They were getting insulin perhaps too early, too aggressively, and as a result, it caused people to gain weight faster. But it's not to say that the insulin was the main driver, nor was the main problem. Insulin was preventing people from going into DKA, which is a life-threatening situation. If you were controlling to hemoglobin A1C of 7, 7.5, you were actually preventing major cardiovascular events. So to say that that was pointless really is losing the nuance of why we were treating those patients then. And again, as we say in this interview, that was before the advent of several newer classes of diabetes medications, which help people lose weight in addition to controlling their blood sugars.
$6,316? Bro, what the fuck? Fuck that. Also, this would never work on a podcast. What, we're going to be in loungers or whatever? Okay, back to here.
It didn't make a difference, and there's a good reason why, and it's because their understanding of type 2 diabetes was fairly rudimentary. They didn't focus on the weight loss part of it. This is the thing that struck me.
Now, he could have more experience on the clinical side than I do, because my experience is nothing, because I'm not a fucking doctor. But just like speaking, I guess like anecdotally or casually, I always throw up a bit of a red flag when somebody's like, doctors didn't care about this thing. They just focused on this thing. Like, it's a doctor. It's not a personal trainer. Yeah, they're just going to prescribe drugs. Like, what the fuck else is he going to do? You're never going to come in with a high A1C and hypertensive, and the doctor's like, listen, I could give you drugs, or you could just get off your fat ass and fucking hit the treadmill, motherfucker, okay? Come back to me with a healthy blood pressure. I'm not giving you any hypertension drugs. I'm not giving you any insulin. Go fucking lose some weight, fatty. Like, that is just never happening. What is a doctor supposed to do? It's not their job. They can't do that.
Rudimentary.
Like, I feel like, are there really doctors in 1999 or like in 2005 that you talk to and you're like, hey, doctor, do you think if this patient lost 100 pounds, it would be good for their diabetes? And the doctor's like, no, I don't think that would matter at all, right? But maybe he's overstating his case a little here. But I don't even know if he would disagree with this.
They didn't focus on the weight loss part of it. This is the thing that struck me as crazy. So at the time, of course, there were not the same number of medications. We treat people with insulin. And so what happens when you give people insulin, right? So you have a type 2 diabetic, their A1Cs are high, you give them insulin, what happens? They all gain weight, right? It's just universal. So patients would go out, I'd give them insulin, because I followed those guidelines, and they gain weight. And as they gain weight, their diabetes got worse, right? Because that's what happens. As their diabetes got worse, you had to give them more insulin, which made them gain more weight. And they all knew this because it was happening to them. And they kept saying, what are you doing to me, right? Like, why are you giving me this insulin that's making me gain 20, 30, 40 pounds? I didn't really have a good answer. But the point...
Am I retarded? This guy will know more than me. You should always defer to this guy over me. But my understanding of the pathophysiology, whatever the fuck you call it, the disease, the way that the disease works is that, like, if you give somebody insulin, a couple things are happening. One is your cells are, type 2 diabetes is characterized by insulin resistance. Like, I think at some point your cells, like fucking insulin receptors, like burn the fuck off. Where it's like, bro, no more, okay? It's too, like, you need to bring 20 insulin friends to come and knock the store down because I'm not opening the door for 18 anymore. This is crazy. So one is your cells, like, over time, your body becomes more and more insulin resistant, number one. But then number two, as you're regulating blood sugar, what are you allowing a person to do when you regulate their blood sugar with insulin? You're allowing them to eat more. Like, oh shit, well, my blood sugar's low. Now I can eat more. I'm not going to die. And as you eat more, whatever your daily caloric intake is, as it increases, assuming your diet isn't significantly changing, you're probably also ingesting more sugar. So as your blood sugar is low, you're eating more because you can, because you're not dying, meaning you're gaining even more blood sugar. And even if you maintained your blood sugar, you're still giving insulin, but now you need even more insulin for the increase in blood sugar that you're taking in. And now your cells are getting even more resistance to the insulin. So you have to, like, that pathway is like, that was my understanding, I guess, for how this worked. And none of that is very mysterious, I don't think, but that's my, I don't know.
Point was that the insulin wasn't doing anything good for them. They're actually hyperinsulinemic. We know that those people had too much insulin, yet we were treating them with more insulin, which was making actually the underlying diabetes worse because they're gaining weight, so their diabetes was getting worse. And we knew it was getting worse because we're giving more and more insulin.
This is so strange because my practical experience is that if I have a patient with a hemoglobin A1C of 8 or 9, and I treat them, in most cases in type 2 diabetes, I'm not jumping to insulin unless their hemoglobin A1C is above 10 or they're very poorly
controlled. Because you do like metformin or some shit first
so
or whatever.
I'm treating them with other medications. Right now, obviously, GLP-1 medications are very popular, but starting in with the basics of a metformin, a sulfonylurea, with all the risks that can come with that, and they do better.
Their blood sugars do better.
But also clinically, they're less likely to be hospitalized. They're less likely to end up with amputations, eye issues.
No, it didn't reduce. So this, remember, first it's 2008. So the GLP-1s and SGLT2s, which I agree are actually quite good medications because they cause weight loss as opposed to weight gain. But the sulfonylureas cause weight gain, and the insulin causes weight gain. So the idea in 2000,
I just don't know if that's true. Can you say that? I mean, like outcome-wise, it causes weight gain, sure. But in the same way that like if you move closer to a McDonald's, that would cause weight gain. But like not directly. You don't like osmosis fat through the air. It's because you're eating more McDonald's. Same way with if you give somebody insulin, does that cause weight gain or does it just like enable them to eat more and then gain more weight? I don't know.
Also causes weight loss as a side effect.
Yeah, a little bit. It's sort of weight neutral. It's not as good as GLP-1s.
Of course,
but, for sure. But metformin is the only drug at the time, right? That was really it was weight neutral. At the time, you had metformin, sulfonylureas, and insulin, right? So by the time you got through metformin, which was what virtually everybody by the time they saw me, they were all heading into sulfonylureas and insulin, which is causing weight gain. So we all expected in 2008, and remember, this is, 15 years ago, right? So we all expected that we would see less microvascular disease, less macrovascular disease, less heart attacks, and less deaths. But it didn't show that, right? That's what it didn't show. And that's why all the guidelines got loosened.
Is that because they were treating with insulin? Because again, this is before my time when I wasn't in medicine yet. I started practicing medicine in 2014. That they were treating with insulin too early? Like they were jumping in and treating with insulin at a hemoglobin A1C of 8 and trying to get it to 6.5?
We all had, the targets were 6.5 at the time. So absolutely,
the starting point is my curiosity. Because I could see if you're starting insulin too early that you may run into.
Insulin sequesters glucose into cells, whereas glucagon takes it out. Insulin, by definition, helps weight gain. It's anabolic. Well, but hold on. Compared to what? An ordinary, like my body produces insulin. Everybody's body produces insulin. Definitionally, it should always be a wash because your blood A1C, your blood sugar level has to be about the same. It's just whether or not you need exogenous insulin to force more. Like, it's not like you're taking a person whose A1C is like 8 and you're pumping them full of so much insulin that now their A1C is 0. And it's like, I absorb all the sugar, everything I eat, every single ounce of sugar shoved into my body. I'll never lose any sugar. Like, you're always keeping them at about the same blood level, right? Like, I don't think that matters much.
Into some issues, but because now the guidelines are starting insulin above 10.
Yeah, but remember the targets were 6.5 at the time, right? So in 2008, the targets were 6.5. So you'd start with metformin, and if you were still at a 7, the next step was sulfonylurea.
Diabetic excrete sugars other ways when untreated, hence sweet urine. Okay, that's true as well. If you want to do the ultra secret weight loss plan of forcing your kidneys to excrete or to like treat your elevated blood sugar, but that's like you're paying for that with your life, no? Like if you really want, like, I don't need to lose weight. My eyes are absorbing the extra sugar. I can't see anymore. My kidneys are dying. Like, I mean, you can absorb blood sugar that way, I imagine, like if it's broken down there. But all in all, I think those are very, very unhealthy ways for your body to deal with sugar in general, no?
And then the next step was insulin, right? Because you only had those.
When was the DPP-4s and the SLG2s? When did that happen?
SGLT2s didn't come out till much later, 2017, 2016, 2017.
Yeah, so my sort of timeline of this is a little bit off.
You may not remember this.
Right, so I guess let's play a little catch up. So now we're in the present, and what is happening now in the diabetic space?
So yeah, in the diabetic space, actually, those drugs are much different because the thing
Thanks, True Conservative Patriot.
is that if you think about what was happening in type 2 diabetes with insulin particularly, because a lot of the patients, because there's only 3 drugs, right? A lot of people wound up on insulin. So for a while, it was, like 5 of the top 10 drugs, like by revenue, was insulins, right? So for a while, it was like a huge, huge seller, right? And that's where a lot of the debate got into with the pricing of insulin and so on. But the whole point was that the insulin wasn't making people better. It was making them gain weight, but it wasn't, and it was getting their A1Cs down. It was getting their blood sugars down. But the question was, where's all that sugar going, right? Nobody really thought about that. It's like, okay, well, you're giving insulin, their blood sugar is 8 or 9, their A1Cs are 8 or 9 or 10. What's happening to all that sugar?
No, this sounds so dumb. My understanding my understanding can't be complete. I must be missing something. Or he's just going to make the argument. I don't know. Everybody would have known this. That's like, is he about to say, well, where's all the extra sugar going? Oh my God, the insulin that we're giving people whose job it is to push sugar into fat cells is causing them to absorb more sugar into their fat cells, and it's making them fat. There's no way he's about to say this, right? Like this is literally the pathway through which insulin works. This would have never, I can't imagine this would have ever been a mystery to any doctor ever, no?
Right? And it's like, well, if you just think about it, what's happening to the sugar. It's all turning into fat because that's what insulin does. It tells you to store that sugar, goes through the liver.
Okay. For my 27th warning, I might be retarded. Wait, hold on. Is this guy actually a super duper diabetes guy? New York Times best-selling author. Well, in that case. He's a Canadian nephrologist and functional medic. Oh. Fuck you guys. Okay, never mind. Okay. Now I'm more skeptical. But let's find out. Hold on.
Becomes through de novo lipogenesis, creates fat. That's what insulin's supposed to do, right? So if you're giving people insulin, you're telling them that they should be gaining more fat. So you're turning that glucose into fat, and that's why all of my patients were gaining weight. But the weight...
No, not really, though. They're gaining weight because they're eating more food. The fat is not invented in your body. You have to eat it, right? Insulin is just dealing with high blood sugar. But to elevate your blood sugar, it's because you're eating food. No?
Gain was the problem, which was causing that type 2 diabetes, right? So we're treating the symptom, gaining weight, but the weight gain was the problem, which was causing that type 2 diabetes, right? So we're treating the symptom of the high blood sugar as the disease.
So would you say in that situation that those patients were over consuming calories, perhaps carbohydrates, and as a result, getting insulin simultaneously, thereby storing it, gaining more weight? You're saying instead of been focusing on the insulin, we should have been focusing on their dietary changes.
Absolutely. And that's where we are.
But I refuse to believe. I just can't ever believe that at any point in time, once we've understood what type 2 diabetes is, that doctors are like, yeah, I don't think eating less would help. I don't think your diet has any impact whatsoever at all, especially because the early forms of diabetes was literally like live monitoring of your fucking blood sugar with a fucking pinprick to measure it and then ingest insulin if you need to, or inject it if you need to, not eating it.
Are now, right? So the most
with my education, for sure.
So the most recent ADA guidelines was weight is actually a huge part of management strategy, right? But this is I don't know when they came out, 2023, something like that. But absolutely, and that's where we are now, right? So the most
with my education, for sure.
So the most recent ADA guidelines was weight is actually a huge part of management strategy, right? But this is I don't know when they came out, 2023.
Okay, I don't trust anything this guy says. Never mind, I'm not buying this. I don't believe this. I feel like this is some alternative medicine weirdo shit. In 2023 was the first time we start recommending people like massively lose weight to help their diabetes. I feel like I don't believe this. Destiny, if they had less insulin, they could store as glycogen or piss out more. If your body doesn't think it's getting energy, it's not going to prepare for it. What? Hold on. You can only store a very limited amount of glycogen, number one. And number two, yes, you can piss out extra blood sugar, but that's really hard on your body. It's bad for you. You're like dying as you're doing that. You're like chronically hyperglycemic. You always have like high blood sugar that causes like parts of your body to start rotting and falling off or not working.
Sure. Something like that. But back then it wasn't. Nobody cared about it. Weight was not even in the ADA. So anyway, to finish off how I got
before 2023? Can somebody, I'm so curious. Is there like a way we can find that? When did doctors first recommend losing weight for type 2 diabetes? Is there any way I could even look this up? The importance of weight management in type 2 diabetes. This is a study from 2014, but it's even decades before this. It's got to be. To say that this just happened in 2023, there's no that's such an insane, but even way before this. Somebody go find it.
Interested in it. So what happened was I realized that we're coming at this all wrong. If type 2 diabetes is primarily a dietary lifestyle disease, and all we're doing is giving medications, you're never going to make it better. In fact, what you need to do is get these people to lose weight. When they lose weight, then their diabetes gets better. Everybody knew that, right? And the crazy part, and I called this one of the ADA's biggest lies, of course they've changed it since then, was that type 2 diabetes was a chronic and progressive disease. So the criteria for remission didn't come in until 2023, so last year. Up until 2023, if you look on the website, the ADA said it's a chronic and progressive disease. But it was a complete lie because everybody knew, nurses knew, I knew, patients knew, if you lost weight, that type 2 diabetes would either get much better or go away completely.
Is that, I've heard back and forth on this. Fuck, can someone just link me this study? I can't use Google Scholar, I suck. I thought that right now if you're, I don't even know if they have the classification pre-diabetic anymore, that you could diet your way out of it, but I don't know if it's been demonstrated. Even if you totally cut out all blood sugar, if you can reverse, because I think that insulin resistance can cause like permanent insulin resistance in your body, that once you progress enough into diabetes, you can never make it better. You can maybe stop it from getting progressively worse. Somebody Google Scholar me. Somebody figure this out.
Everybody knew it.
Well,
but I'm fairly certain that if you catch it, if you're like pre-diabetic before you're ever on insulin or whatever, and you do severe changes in your diet, I believe you can reverse or not become diabetic. But once you've hit diabetic, I don't know if you can. Hold on, let's see this. In the mid-1600s, Thomas Willis introduced carbohydrate restriction and limited his patients to a diet of milk and barley water boiled with bread. In the 1700s, the meat diet additional guy. Around the end of the 19th century, Sir William Osler, the father of modern American medicine, recommended that diabetes patients consume a diet of 65% fat, 32% protein, and 3% carbohydrates straight from all fruits and garden stuff. Damn, this was in the 1800s? Around the end of the 19th century. Okay. Despite all these heroic diets, the prognosis for patients remained uniformly grim until the discovery of insulin by Banting, Best, and colleagues in Toronto, Canada in 1921. This is a systematic review and meta-analysis published in April of 2022. Several interventions have been found to be effective for reversing pre-diabetes in adults. Okay, but what about like once you're full-on diabetic? At a median follow-up of 1.6 years, more participants in the lifestyle modification groups achieved normoglycemia than those in the control. The strength of the evidence was strong for lifestyle modification. Over a median follow-up of 2.7 years, more participants receiving glucogen-like peptide, one receptor agonist, glucose inhibitor, achieved normoglycemia than control. The strength of evidence was modified several. Can reverse pre-diabetes, lifestyle modification provides the strongest evidence. Okay. I don't know if there's ever been evidence, I think research-wise, that you can reverse diabetes once you have it. But I could be wrong on that. I'm not sure. Or, I mean, no, I'm not wrong. I haven't seen it. Behavior change, weight loss and remission of type 2 diabetes, a community-based prospective cohort study. We conducted a prospective cohort study in 867 people with newly diagnosed diabetes aged 40 to 69 years. From the Addition Cambridge trial, participants were identified via stepwise screening and an assessment of weight change, physical activity. Diabetes remission was achieved in 257 patients, 30% at a 5-year follow-up, compared with people who maintained the same weight. Those who achieved over 10% weight loss in the first year after diagnosis had a significantly higher likelihood of remission. The subsequent 1 to 5 years, achieving over 10% weight loss was also associated with remission. Is this all American? It's like the same definitions of like pre-diabetic or diabetic. So this shows that of 867 people, did all of them lose weight or? Percent of weight changes. Okay, results. 30%. People maintain the same weight. Those who achieve over 10% weight loss in the first year, certainly likely. Wait, compared with people who maintain the same weight, those who achieved over 10% weight loss in the first year after diagnosis, had a significantly higher likelihood. Okay. Weight loss of over 10% early in the disease trajectory was associated with a doubling of the likelihood of remission at 5 years. Okay. I think remission just means that your blood sugar is at normal levels, not cured. Sure. Okay. All right, back to this. Sorry.
That type 2 diabetes would either get much better or go away completely. Everybody knew it.
Well, the disease itself, in terms of the sugar regulation, could be managed, maybe put in remission. I guess it's like a issue of vocabulary.
Yeah.
But the risks that were created by becoming a quote unquote type 2 diabetic, of having a higher risk of ASCVD, of kidney issues, of peripheral neuropathy, those risks stayed elevated. Is that fair to say?
If you're
compared to a
A1C
person who's never had an abnormal A1C.
It's still elevated because they still have some insulin resistance.
exactly.
But, if you have somebody, say you have somebody who's A1C of 8, 20 pounds over, and compared to an A1C of 6 and 20 pounds less, like I think their risk is much different, right? And the point was that at the time, we weren't focused on getting the sugars down through dietary control, and neither were we focused on getting that weight down either. Nobody cared. We were plying them with so much insulin that they couldn't.
God, I hate this. I don't like this guy. I'm running out of patience for this guy, but okay. Hold on, I'm sorry. Let's
Any
get a
treatment for my
better explanation for diabetes. Here we go. Finally.
Any treatment for my type 2 diabetes.
There's absolutely no part of that sentence that is true.
I've been experiencing weight gain, fatigue, and sluggishness.
Weight loss is a symptom of diabetes. Fatigue is a symptom of thinking you have a disease you don't actually have. And sluggishness is a synonym of fatigue.
I need insulin. I know it.
Much as I'd like to kill you by dangerously lowering your blood sugar, murder violates my parole.
That blood work is weeks old. Test me again.
I am the test. The test is negative. The test also thinks you're a giant pain in the ass.
Damn. Wow.
That last insult was your cue to leave.
Test me.
Fine. Here, right here.
Thank you.
Sleep study. Please make sure he's not disturbed for the next 8 hours.
Test my urine.
Looks like I was wrong about my diagnosis.
Yeah, I have diabetes.
No, but you're not a hypochondriac. Or you would have imagined some new disease after I shot down the first one. So
Okay. Good enough. Thank you.
Lose weight, right? And I saw it day in, day out because I'm a kidney specialist. I see
You would see the worst
mostly-
cases,
Yeah,
yeah.
I see the worst cases, and almost my whole practice is like because
that, for
because
sure.
it's just it's much more common than polycystic kidney disease. or
Yeah,
other
I think
diseases.
where, again, I came in 6-7 years into medicine after that, seeing bariatric surgery cases where we saw the biggest cases of remission after a drastic 40% of body weight being lost, where everyone hesitated to use the term cured.
Right.
But we saw drastic improvements where now it could be managed with just dietary control
Yeah.
as opposed to getting medications on board. And perhaps we still recommended some preventive medications, managing blood pressure more thoroughly by getting an ACE inhibitor on board, managing cholesterol a little bit more aggressively because we consider them high risk by getting a statin on board. But in general, I think bariatric surgery provided us a really good window into seeing how drastic weight loss can impact
Absolutely.
diabetes.
And at the same time, we had all these studies of bariatric surgery, which basically proved that it was a reversible condition, right? Because it's defined by that A1C greater than 6.5 on no medications, right? That's how you define type 2 diabetes. So when you change their diet, and this was a very drastic measure, of course, right? But that diabetes came down like within a month, like within weeks. Those sugars came right down. That's what all the studies showed. So if it's reversible, why would you tell people it's irreversible, right? It's all.
Well, I think
due
they were
to
talking about the
diet.
risk.
I feel like okay. Dr. Mike is right here in that you're playing games with a couple other things too. I don't know how true these are, and I can't look up everything, and I'm not a doctor. Bariatric surgery is when you fucking put a giant fucking fleshlight around somebody's stomach and you fucking clamp down on it. And you go, oh, stop fitting so much food in here. Oh yeah, Presser is putting it in here in chat too. Type 2 diabetes might be defined as, I actually don't even know if that's true, if it's defined as the high presence of blood sugar, but I believe I think there are two other things that happen when you're a type 2 diabetic. One is insulin resistance, meaning your body has to produce more insulin in order for your cells to actually pay attention to and absorb the glucose in your blood sugar. But two, I believe that it's possible. This is why I think long-term, like chronic diabetes is incurable, is I think your beta cells can literally just kill themselves in your pancreas, right? When you have had type 2 diabetes for so long, because they are making so much insulin, they can't do it. It's overproduction, and eventually they kill themselves. They're like, this is fucking retarded. And then it's basically the same as being a type 1 diabetic, where type 1 diabetes is not characterized by insulin resistance. It's characterized by, it's an autoimmune disease that attacks the beta cells or whatever of your pancreas that produce the insulin. But I think that those cells die over time permanently, I think, in a type 2 diabetic patient. So you might be able to lower your A1C, but I don't know if those other two things, the insulin resistance or that beta cell genocide, like go away. I'm not sure. I don't know.
Risk.
The risk of what? The risk of
That the risk stays elevated. That you can't really reverse the risk. I think that's the thought process.
Okay, but the diabetes
itself
is reversed.
I would say it's controllable, but the risk is always ever present.
Well, according to current, like this is since 2023, it's considered in remission, right? That's the term.
Yeah. But and also like why pre-diabetic range is so interesting. It's the range that is considered the time where you can reverse it.
Yeah.
And completely stop the progression.
So what he's saying, that's what we just looked up. I think that is true. Pre-diabetic, I think it's accepted that with lifestyle changes, you can fully not become diabetic.
Into type 2 diabetes.
But it can be reversed in that you can go from diabetes into diabetes in remission to pre-diabetes and beyond, because these are all defined, right, by the A1C.
And honestly, these will change as time goes on, as we get more data. So
but the point being that up until 2023, nobody ever said that this was a reversible disease. It could not be reversed, which was crazy, because it's like, yes, I can get that A1C down from 8.
I think that pre-diabetic, I don't know.
Down to 5.5. Bariatric surgery proved that, right? And not over a short period of time, like really fast, right? Those bariatric surgery trials, if you remember, that before they lost a significant amount of weight, their A1Cs came down to normal. It was like 2 weeks, right? 3 weeks. And the sugars were completely normalized, right? So it's long before the rest of that weight loss took place. There was something happening there that, and from 2010, 2012, when all these bariatric surgeries came out, that's 12 years before the American Diabetes Association said, yes, it's reversible, because it's really important to tell people that it's a reversible disease. Because if you tell people it's an irreversible disease, they'll be like, okay, I get it.
Yeah, it's demotivating to hear
Exactly.
that. Yeah, I think it's like in science, we get very caught up in the nuance of vocabulary.
Yeah.
And we sometimes put too much emphasis on it, because in a condition, whether it's reversible, remission, curable, at the end of the day, what's the practical implication?
Exactly.
We don't want to demotivate patients, so keep them as motivated as possible and say there are factors that are under your control that are valuable. Which at the same time, you want to be careful, because it's easy to get into then a victim blaming situation where it's this diabetes is your fault, and that could also be demotivating. So there's a range and barometer. Of
but to me, it's like you got to tell people the truth.
For sure.
If it's reversible and if it's largely a dietary disease, then that should be the first message you give people.
The line between type 1 and 2 is whether you can endogenously produce insulin. Type 2 is generally considered an abnormal response to insulin. I feel like type 1 and type 2 diabetes aren't related at all. I would be super triggered if I was a type 1 and it's even given the same name. Because type 1 diabetes, I think, is characterized chiefly by just an autoimmune disease. Like, I don't know if there are other ways where your body dies of, where your beta cells die, where you'd be considered a type 1 diabetic. I think it's almost always an autoimmune disease. And type 2 seems to be largely a lifestyle related to disease, where you can have some genetic predisposition towards developing it easier than other people. But
it's a dietary disease and it's reversible. Let me help you do that, which is what they didn't say, right? And that's where I say, well, that's really tough, because I remember telling patients, look, this is a reversible disease. So just to finish, so what happened was I started to realize that weight loss was really important, which of course everybody agrees on. That's actually in the standards of care for in the latest sort of 2024 American Diabetes Association guidelines. Weight loss is actually quite critical. But I realized that weight loss is really important, and that's where for American Diabetes Association agrees on. That's actually in the standards of care for in the latest sort of 2024 American Diabetes Association guidelines. Weight loss is actually quite critical. But I realized that weight loss is really important, and that's where I became super, super, super interested in weight loss, because if you could get people to lose weight, then you could reverse their type 2 diabetes, which means they never got diabetic kidney disease because they don't have diabetes, right? Or you'd reduce the risk at the very minimum.
Yeah.
So then I started talking to people about a couple of things. One is lowering their carbohydrates, right? And again, it's not a new thing. Like, cutting carbohydrates has been around a long time. And if you look at the American Diabetes Association nutrition guidelines, the scientific guidelines, they say there's actually the most data. This low carb diet has the most data of any diet for control of blood sugars. And that makes sense, right? Because if you eat white bread, you know that the blood sugar goes up. If you eat an egg, you know the blood sugar doesn't go up. So eat less of the white bread and eat more of the egg. That's sort of the blood sugar goes up. Diet. Diabetes Association nutrition guidelines, the scientific guidelines, they say there's actually the most data. This low carb diet has the most data of any diet for control of blood sugars. And that makes sense, right? Because if you eat
I could be wrong. I got fact checked because I said what he's saying before, and I think we looked it up, and this is not true. I don't believe that glycemic index has anything to do with healthy functioning of your body, being able to reduce your blood sugar, assuming you don't have diabetes. That you can eat white bread, you can eat dark bread, you can eat whatever the fuck you want. That glycemic index stuff is not really relevant to a healthy person who is not even pre-diabetic. Your body will always be able to manage your blood sugar. You can spike your blood sugar as much as you want, it doesn't matter. Now, as you gain more and more weight, as you consume more and more over time, that maybe you'll become type 2 diabetic, but eating high GI foods versus low GI foods, I don't think has any impact on that whatsoever, is my understanding.
Eat white bread, you know that the blood sugar goes up. If you eat an egg, you know the blood sugar doesn't go up. So eat less of the white bread and eat more of the egg. That's sort of logical, right? And then I started talking to them about intermittent fasting. So this is in 2010, 2011. And at the time, again, you have to remember that everybody thought it was the dumbest thing they'd ever heard. Intermittent fasting, not eating, was known to kill people, right? There was so much bias against that.
What?
Fasting, not eating, was known to kill people, right?
I just don't trust anything this guy says. Isn't it a sensitivity thing? So anyone using more insulin will worsen the capacity of it? I don't believe that's the case. I wasn't able to find any research when I got called on this like a few years ago, and I looked it up, and it seemed like as long as you're not diabetic, you can spike your blood sugar as much as you want. Your body will always regulate it. But this idea that like nobody, like people thought intermittent fasting would kill you. Really? I don't believe this. Sorry, can you clarify why you don't trust him? Okay, well, initially I said something at the beginning, which diabetes is like one of the realms of like bullshit pseudo guru doctor people or whatever. But apparently this guy is like has a book and is, I guess, respected. But he's just said so many things that are just not really true at this point. Or he's overselling. I hate that I looked up and I saw he was a functional medicine guy. Anytime you get a guy who's here, this is what I'll say, heuristic. Anytime somebody tells you doctors don't even know that if you just live a healthier lifestyle, it'll make you healthier. They didn't know that until 2024. Really? Really? Doctors just discovered in 2024 that if you lost 100 pounds of fat, it would help you with probably every part of your body. Really? That's when they learned that? It was with the statement in 2023 and 2020. Come on. I don't know. He's overselling it so much. It feels really goofy and stupid to me. Like he's trying to sell me some fucking miracle cure or some bullshit.
That everybody thought it was the dumbest thing they'd ever heard. Intermittent fasting, not eating, was known to kill people, right? There was so much bias against that. And
like who's saying that intermittent fasting, what is it called? Time restricted eating is going to kill you? I just don't believe it. I don't believe that this was ever a thought. I don't believe it.
I said, well, let me look at the data here. What's so bad about it, really? What happens to your body when you fast? Mm-hmm. And it's like, well, if you're diabetic, if you're overweight, if your blood glucose is high, nothing bad happens. Remember that your body has the ability to store calories. It stores calories, which is a form of food energy in the form of glucose, right? You can store glycogen, which is chains of glucose, and you can store body fat. When you don't eat, your body is going to start burning the glucose or start burning the body fat. And you have too much of both. Therefore, if you fast, that's all that's going to happen. And it's a completely natural process. It happens in everybody. Back in caveman days, people were fasting all the time, whether it's voluntarily or involuntarily. It's the very reason you have body fat. It's not there for looks. It's there for you to use when you don't eat. And as a doctor, I had been prescribing fasting to patients. Pre-op, you have to fast. Colonoscopy, you have to fast. Post-op, you have to fast. Treatment of pancreatitis, you have to fast. For fasting blood glucose, you have to fast. So it's like, okay, if I'm telling people they should fast for all these reasons, then why can't they do it from a therapeutic standpoint? It doesn't make any sense, right? So I told them, you should fast, and I started them on a fasting regimen, and it was crazy.
What regimen did you choose?
I used a 24-hour fast 3 times a week for my patients, and that was just because, at least you're eating once a day, and they could take their medications if they had pills and stuff. It wasn't too much, and it wasn't too little I wanted to go gently.
Got it.
And so I had this one patient, which I wrote up as a case report. I had been treating him for like 10 years. He was on 120 units of insulin, and he was very dedicated, wrote down everything, wanted to know everything. So I told him, you should try this, right? And keep track. Within a month, he came off all his insulin, all of his blood pressure, all of his blood sugar pills, and his A1C went down to like 5.9. I'm like, holy crap, in a month. And then I had 3 of these cases in the first 6 months. I had 3 cases just like that. And I thought to myself, holy crap, I've actually been doing all my patients a huge disservice. I've been treating them for the last 8, 9, 10 years as a type 2 diabetic that had it for the rest of their life, and they would inevitably go on to nephropathy.
Jesus, sorry.
All my patients a huge disservice. I've been treating them for the last 8, 9, 10 years as a type 2 diabetic that had it for the rest of their life, and they would inevitably go on to nephropathy when that type 2 diabetes was completely reversible. You got to recognize that we call it diabetic nephropathy. It's like if you don't have diabetes, then you're going to have less chance of getting the diabetic nephropathy. It happens, but it's unusual. So it's like, okay, that's crazy. All because I didn't focus on the right thing. And that's where I started really to think about both weight loss and fasting as a therapeutic tool.
So the summary of it would be that you started seeing this uptick as a result of the huge spike in people gaining weight. being overweight, obese, then developing diabetes, then developing kidney disease. And instead of just treating the condition, you started thinking more preventively. How can we get ahead of this?
Yeah.
And the dietary aspect, the weight loss diet, the weight loss aspect was probably the most efficacious way of doing it, which we see now and we're talking about more so these days. Why did you choose fasting specifically as your approach to helping people lose weight as opposed to the low carbohydrate diet, caloric restriction, keto? You know, there's all sorts of avenues by which people try and lose weight.
I mean, it's just another tool. You don't have to fast to lose weight. You can lose weight actually a lot of different ways. You can use low fat, you can use low carb, you can use carnivore, you can use vegan. They actually all work, right? There's a lot of stuff that works. But it was something that people had always done. So the funny part about fasting is that there's so many advantages from a weight loss standpoint. So if you do caloric restriction, most people have zero idea how many calories they're eating in a day. It's actually very difficult because if you buy broccoli or steak, you have no idea how many calories are in that piece of steak or whatever. If you fry it up with, butter or without butter, what sauce you put on it, all these change how many calories you take. So it's a complete guess how many calories you're eating and a complete guess how many calories you're burning. And the amount of calories you're burning actually fluctuates because some people try and measure it, I'm burning 2,000 a day. Well, that actually can go up or down by like 40%. It can go up and down a lot. So you have no idea how many calories you're eating. You have no idea how many calories you're burning. How are you supposed to actually use that as a therapeutic strategy? As opposed to simply saying you should not eat for 16 hours of the day or 24 hours of the day. Oh, well, it's very easy to figure that out. If you only eat once in a day, then that's it. You're following the rules, right? So as a therapeutic strategy, it's much, much more effective. So there's a huge
So the practical aspect.
Practically, yeah. It was something that people had never done. Like at the time I started using it, 2013, 2014.
I do agree with this, unironically. He's making it a little bit more woo-wee than it is. But like if you do time restricted eating or intermittent fasting, it's nice because you limit yourself from making bad decisions. Like if you say, even if you have big eating windows, like 10 hours or whatever, like I'm only going to eat from 10 a.m. to 8 p.m. Like chances are, if you're an American, anything you eat past 8 p.m. is never, ever anything good for you. Nobody is ever eating a super ultra nutritious snack at 2 a.m., when they're watching TV. Or if you just wake up, like grabbing whatever small candy bars, whatever, like time restricted eating is nice or intermittent fasting is nice just because it locks you into a certain time window and it keeps you from making bad decisions, I think.
Like zero people thought it was a good idea, right? I mean, it seems strange now because it became very popular. But I published the Complete Guide to Fasting and the Obesity Code in 2016. So I started using it around 2012, 2013. And there was nobody who thought it was a good idea. Even up until about 2020 or so, people were still really against fasting. But the
Why
idea,
do you think people...
I just don't agree with any time he says people were really against this. I don't believe this. Like if you're able to fast for 24 hours, bro, good for you. I'm curious, like when he talks about these 24-hour fasts, what's your attrition rate on these studies? Are you getting like 100 people signed up and then like there's 8 left by the end and these people all have like stellar results? Yeah, because you found the 8 people who are willing to do fucking 3 days a week of 24-hour fasting. That's an exceptional commitment to a diet, my friend. Jesus.
good idea. Even up until about 2020 or so, people were still really against fasting. But
Why do you think people were against fasting?
I think it's because it was not something that they had heard of before. So then people just thought, oh, well, if I hadn't heard of it, it's got to be a bad idea, right?
Am I biased because I'm Catholic? I feel like every religious person in the history of the planet knows about fasting. No? Like every Christian, every Muslim, who hasn't heard of fasting? Am I...
You mean the general public, academics, doctors?
The general public was much more accepting than academics and doctors. They are the slowest.
And you believe that academics and doctors never heard of fasting before this?
Yeah, like what? He's asking this so gently. Like you think doctors don't know what fasting is? Like never?
They never recommended it. Or when they talked about it, it was in a, like, you shouldn't do it sort of an idea. Never
What was
skip
their
your meals.
concern?
I bet if a doctor says you shouldn't fast, it's because you get a person who comes in. I think one of the worst things that you can do. And actually, if you're talking about like these 24-hour fasts, my guess is going to be these are probably overwhelmingly negative for patients to recommend on a first pass, because all you're setting people up for are hard crash diets that they will never be able to fucking stick with. You recommend you're better off with like a Coke Zero diet. Like, listen, you eat all this crazy shit, you drink, just replace all your fucking sodas with Coke Zero, okay? At least let's start there, More likely to be successful with that than taking a 350-pound person. You're like, okay, 3 days a week, motherfucker, you're not eating. That dude is quitting your diet like 98% of the time, and he's gonna feel like shit afterwards. Like, there's just no way.
I don't know that they had legitimate concerns. Their concern was that if you didn't eat, then you would binge eat afterwards, which
I bet a lot of them did.
can be a concern. But on the other hand, if it is a problem, like it can happen.
Sure.
But everything has its problems. If you restrict certain foods, you don't eat sweets, which is a good idea. You might binge, right? If you don't eat chips, you might binge when you get out. Like that's the college 15, right? So there's a risk with all of that. But the whole point is that you might binge. Everything has its problems. If you restrict certain foods, you don't eat sweets, which is a good idea. You might binge, right? If you don't eat chips, you might binge when you get out. Like that's the college 15, right? So there's a risk with
Am I being super nitpicky? The college 15, I feel like this is just referring to like you go to college and you stay up late and you eat more and you drink a ton of beer or whatever, and over time you just get a little bit fatter. That's not just like you binge eat sometimes. Isn't that just like college lifestyle and you gain? I don't know. Now I'm nitpicky.
With all of that. But the whole point is that if you think about intermittent fasting as a strategy for weight loss, it's simple, right?
Or it's the freshman 15, not the college 20. Sorry.
Everybody understands it, right? It's free. So it's not like I'm telling you to go to Whole Foods and buy like all organic, grass fed, this and that, right? That's going to be so expensive, but that's not accessible. This is free. It's convenient, right? You're not putting more time, right? You're not like, oh, I need to do this and this and home make all my meals. It's like you're not eating. So you're taking less time than before. You're taking less money.
That's so ingenious. Where's my Drake GIF? Why do we not have this as a fucking GIF in chat yet? Oh, bro, have you ever thought, there are 7 days in the week? Just don't eat for half of them. Fuck, I'm saving money, less calories, more free time. Like, oh shit, why didn't I think of this? All the doctors were hiding this one simple trick, just stop eating.
It's and it's, you can change it up. Like you don't have to always do it. You can do it more this week, and then next week if it's Thanksgiving or if it's Christmas or whatever, you can decide not to do it and then do more the week after, right? So a huge number of advantages. But the main,
like what he just described, and fuck me, dude, I don't know. Maybe he's got more. I don't have any patience. What he just described sounds like the worst fucking diet plan ever. Listen, here's what we're gonna do. You don't have to do it sometimes, do it not all the time, however you want to do it, but just every now and then, just skip a day's worth of eating, okay? You can do it a lot this time, and next week, maybe not as much, but this just sounds like the worst diet plan ever. I don't believe that on the aggregate, you could get a bunch of people to stick to something like this. I don't believe this. Well, but maybe he's just talking in the early stages, and this isn't what he would recommend everybody, but.
The main thing is that if you look back, people have been doing it for thousands and thousands of years. Like, I didn't make it up. I mean, you can find lots of references in virtually every single major religion, which means that even back,
Yes. Don't we? I forget for Catholics. Does everybody do Lent? Are we supposed to fast over Lent, or am I making that up? I don't even fucking remember how long Lent is. Is this 40 days of bullshit, or is that 3 days? It's 40 days. Weren't we supposed to fast, or am I making this up? Yeah. Like, there's a lot of most people on the planet, I'm pretty sure, are religious. So I think most people have heard of this.
2,000 plus years ago, people had talked about fasting as something which is very healthy for you, right? It wasn't, when they talked about fasting, my priest used to talk about it every Easter, right? Around Lent. And he talked about fasting.
Oh, he's Catholic.
And purification and praying and all this sort of stuff. And I remember thinking at the time, I don't think anybody fasts. We're all told not to fast. You're the only one who ever talks about it. But, clearly, it's in that tradition, and you can find it in Buddhism, you can find it in Hinduism, you can find it in, Islam. You can find it in every religion, and it's not ever in a negative connotation. It's not like you're fasting because it's punishment for you, right? It's like, oh,
well, kind of. What do you mean? It kind of is negative. You're fasting to give something up. It is negative. It's like releasing a vice, like in the same way that like self-flagellating it's a way to free yourself of to give up something in observance of something else. It kind of is a punishment, no?
Oh, you need to fast to make yourself better. Yeah, it's always a choice. And that's the important thing, because I always...
But to make yourself better, like spiritually, like spiritually, not physically.
Get this thing, it's starvation. No. Fasting is the voluntary abstinence of food. You could eat, but you choose not to eat for whatever reason. It could be religious, it could be weight loss, it could be whatever. But the point is that if you fast, if there's something wrong with fasting, like wouldn't we have figured this out like 2,000 years ago?
I mean, I hate to harp on extreme.
My guess is when most people fasted a long time ago, it was either for super religious reasons or it's because they were starving to death. Well, like...
I'm just going to point out the devil's advocate of it, is that there's a group of people who believe that it can fuel an eating disorder, where they say starting to think in this way of withholding food can create perhaps an unhealthy relationship. I don't think that's the general case for most people. And I also think it's unfair to take away a strategy from a great sum of people because there are people who can be harmed by it. Because just the topic of talking about weight loss can be unhealthy for one individual who perhaps has disordered eating versus there's still value in talking about weight loss for those who are morbidly obese or obese, what have you.
I think it's a legitimate point, because it's like saying that, it's a tool, right? Fasting is a tool, just like everything. Low carb is a tool, calories is a tool, everything's a tool, which means that it has the ability to hurt you and it has the ability to help you. You have to know how to use it. It's like a knife, right? It can kill somebody, or if it's a scalpel wielded by a surgeon, it can cure somebody, right? It's the same knife. You don't ever say, oh, knife bad, must not use knife. It's like, okay.
Maybe hammer's a better analogy for that one.
Hammer, yeah. But you know what I mean, right? So fasting, yes, there are definitely problems. That's why you need to know about it and know how to use it. And fasting does not mean 40 days and 40 nights, right? It can be any length of time. You think of the very word breakfast. Breakfast. It's the meal that breaks your fast. if you don't fast, you cannot ever break your fast. So therefore, even from the beginnings, the origins of the English language, we acknowledge that there's a period of time that you should be feeding, and that's when you're going to store calories, right? Insulin goes up, and we know the physiology has been so well worked out. You eat, and assuming you're eating a variety of foods, your insulin's going to go up, you're going to store calories, because you eat, say, 1,000 calories
Of course,
at
you're not going to
dinner.
burn it off right away.
Exactly. You can't burn it off. So you need to store some of it. Why? Because you don't want to die in your sleep. So you store it. Then when you fast, when you're not eating after dinner, right, 12, 14 hours, your insulin's going to go down. Now you're going to pull those calories back out. So you fast from, say, dinner, say it's 7 p.m. to 7 a.m. That's a 12-hour fasting period. Then you break your fast, or if you don't eat breakfast until 10 o'clock, right? You sleep in, it's 10 o'clock. You're talking 13 hours. And people did that every single day without calling it a fast, right? Then all of a sudden in 2019, 2020, it's like, oh my God, you shouldn't be going more than 6 hours without stuffing your face, even to lose weight.
It's so interesting. I never.
Who? Nobody's saying this. I feel like he's like bastardizing the sayings of like eating like small snacks or healthy snacks throughout the day might be better than just binge eating huge meals. I feel like he's just like horrendously misquoting that.
never came across, because I also talked about intermittent fasting at some point when we started the YouTube channel. I never got feedback that intermittent fasting was terrible. The only feedback that I got, which I think is very accurate, I'm curious if
Okay. Is he about to say it? It's not that intermittent fasting was terrible. It's that people can set themselves up for failure and then end up binge eating and then feeling more discouraged with themselves.
you agree that the reason why intermittent fasting works is that it's
Shit. Okay, never mind. He's going with why it works. It's because it keeps you from eating at stupid hours and eating dumb shit. It just restricts calories.
another way of lowering calories consumed because you're eating in a smaller time window.
Yeah, so I think there's some truth to that, but the whole calories thing is a whole other debate I have with people. So one is that it is a way that you're going to eat fewer calories because it's actually harder if you compress the time that you're eating. And there's lots of studies to back this up. It's harder, right? If you take 3
And harder to
meals-
absorb.
Yeah, exactly. So a lot of it's going to pass through. But if you compress the time you eat, it's harder because you get full.
Of course, yeah.
right? So you can't eat 3 meals at one meal. It's very difficult.
Less
So-
snacking.
Less snacking. So the
Is that a challenge?
compressing it does make you eat fewer calories. But I think there's actually another benefit to it, which is the hormonal benefit, which is what I talk about a lot because it's like, to me, the idea that it's all about calories is highly destructive because it leads, I think, in one sense to this sort of blame game, blaming the victim, where it's like, it's all calories in, calories out, and therefore it's all your fault if you're overweight, that you should eat less.
I don't remember what it was for, but there is some hormone or there's something where I think IF or time restricted eating is what they call in the research. I think actually does benefit you a little bit hormonally. I don't remember which hormone it was or what exactly it helped with, but I think that time restricted eating I think can help with that. But I don't remember what it was for.
So you should exercise more. That whole idea is, this whole idea of fat shaming and all that stuff. I think it's a little bit destructive because I don't think that it comes down all to calories. I think that it also depends on the hormones, primarily insulin, right? You need to lower insulin in order to lose weight.
How do you lower insulin though?
What?
The hormones, primarily insulin, right? You need to lower insulin in order to lose weight.
How do you lower insulin though?
There's lots of ways. So
Taking in
low
less
carb
calories?
diet. Less calories will definitely do it. But the point is that there's there's an overlap between calories and insulin. But certain foods raise insulin more than other foods, right? So if you eat a cookie, like 100 calories of a cookie.
He's talking about the glycemic index stuff. But that's just because it gets broken down so much quicker. Your blood sugar elevates faster because it's easier to digest. It's simpler, simple sugars and shit, and highly processed food, right?
Your insulin's going to go way up. If you eat an egg, it's not going to go way up because it's mostly proteins and fats. So the idea that you can take two 100-calorie portions, so 100 calories of cookies, 100 calories of egg or broccoli or something like that, and the people who say it's all about calories will say they're equally fattening because they're both 100 calories. I'm like, there's no way they're equally fattening, right? Because they're different. This one will spike your insulin. Your glucose will go up. The cookies, your insulin will go up. Your glucose will go up. What does the insulin do? Well, we know what insulin does. It tells your body to please store those calories as either sugar or fat because that's the way it is. So you take 100 calories of cookies, insulin goes up, you store those 100 calories directly into glucose or body fat. Well, there's nothing left for your body to use, so you're still hungry. So you go ahead and eat, right? If you eat an egg, well, the insulin doesn't really go up, so it's still circulating around. You've still got 100
But insulin
calories.
does go up.
With eggs?
Yes, of course. With eggs, everything is ultimately broken down into I feel like the graph, what he's describing, like if he were to give advice based on this, I think he'd be correct, but just for weird reasons. But it's like I'm pretty sure, like if you were to measure your insulin over time, the cookie would look like this or whatever, but like the egg would end up looking like this. But if you took the area under both these curves, they would still be the same. I think, I don't know if it would be exactly the same. There might be more complicated reason why it would be a little bit different. But like you still have to do something with all that sugar that's being created from the food that you're breaking down. Like, of course, your insulin is going to go up when you're eating anything, except for stuff that you literally can't digest, right? Like fiber or something. I don't know.
Or body fat. Well, there's nothing left for your body to use, so you're still hungry. So you go ahead and eat, right? If you eat an egg, well, the insulin doesn't really go up, so it's still circulating around. You've still got
But
100
insulin
calories.
does go up.
With eggs?
Yeah.
Not really a lot. So protein,
Well, yeah, it'll
Why would he say that? That's such a weird thing to say.
spike less.
a lot less.
And there's also the thermic cost of breaking down the proteins, which will
Thermic cost is almost nothing, isn't it? Isn't that like a negligible? Didn't people try to, or am I thinking of a different thermic thing? That at some point people are trying to say some stuff is difficult to digest, so your body is less efficient. I thought that for the most part, we digest most calories like pretty well. If somebody has a link to thermic cost of food digestion, I'd be interested in seeing it. I feel like that's not a significant difference. I could be wrong on that though. But
Well, yeah, it'll spike less.
A lot less.
And there's also the thermic cost of breaking down the proteins, which will decrease the amount of calories absorbed, therefore lower the insulin spike.
Yeah. The thermic effect of food is relatively small.
Yeah.
But,
Yes.
but clearly those two foods have very different insulin profiles, right? We can measure it. You can do a glycemic index, right?
Right, yeah.
Easy as pie. One of them's very high. You eat white bread, glycemic index of 95. You eat an egg, glycemic index 0. So
yeah, but your blood sugar is probably elevated for a longer period of time, would be my guess, because it takes you longer to break it down into the simple sugar, would be my guess. Is there like a profile? Is there like a blood sugar profile for consumption of protein versus simple carbohydrates or something?
insulin, which follows fairly closely for that, is going to be the same. There is going to be some insulin rise with protein, but protein tends to raise both insulin and glucagon. But either
I
case,
don't know anything about glucagon.
it's a lot less insulin than white bread or cookies or something. So to protect
Wait, is glucagon what's used to make glycogen? Glucagon. Nope, just kidding. I don't know. Glucagon is a hormone that your pancreas makes to help regulate your blood glucose levels. Glucagon increases your blood sugar level and prevents it from dropping too low, whereas insulin, another hormone, decreases blood sugar levels. Oh, okay. What does this do? Just sucks fat of your cells, basically, or it takes sugar out of cells into the blood? Okay.
pretend that change in insulin makes no difference to people. Why would we do that, right? I'm not asking if the two are equal calories. We're setting the two as equal calories, but the minute you put them in your mouth, your body is going to respond very differently in terms of the insulin.
But I think the people who talk
Like what he's saying is true. I just don't know why you would focus on the insulin part here. Dr. Mike's going to set him straight. The problem is because your body breaks it down so quickly for like a cookie. Your insulin might spike, which could be a good tracker, I guess, of how satiating food is. But it's not satiating. You're going to be hungry like an hour or two later. Whereas like the stuff that takes longer to break down keeps you satiated for longer. I feel like is the big difference here. But maybe that ties in really closely to insulin. I feel like insulin just is a proxy for this, but it's not like the causal thing. I don't know.
talk about calories in and calories out, I mean, I'm one of those people. I don't think we equate each calorie being identical. I think we just kind of zoom out and look at it more practically and holistically and say, if you look at the studies that have changed the amount of carbohydrates one group consumed literally in human trials and metabolic wards, and said, if you feed less carbohydrates to one group of people, more proteins and fats to another group, or swapped it the other way around, you see the same weight loss depending on the amount of caloric intake they have. The one difference that I could see that happens is, from an insulin standpoint, is perhaps behavioral change, because there could be a craving effect that happens
Because of the lack of satiation of simple sugar stuff.
that can create a person wanting to eat more often or snack more often or consume less healthy choices. But to say that the fact that a certain calorie, depending on which macronutrient it comes from, will impact the amount of weight loss hasn't really been borne out by evidence.
Well,
Oof. Uh-oh. That's probably a big part of this guy's life.
there's also no trials that have shown that if you reduce calories without affecting anything else, that you can actually lose weight in the long term.
If you reduce calories without affecting anything else, how could you even possibly do that? Wait, what? What does that even mean? Oh, Dr. Mike just got hit with the impossible trial.
There's also no trials that have shown that
No trials have actually measured what it looks like if you eat less without actually putting the food in your mouth, though. Like what?
if you reduce calories without affecting anything else, that you can actually lose weight in the long term. So all of those studies, like Women's Health Initiative, like DPP, they're all like, a kilo of weight loss over like 6-7 years.
Well, the failures in a lot of these studies is that keeping weight off with diet and exercise is very hard. And
Yeah.
the reasons for that, I don't think most people would say is because of insulin.
Oof.
You see, I have a different opinion. See, again, I think there is a difference in terms of eating behavior, and you alluded to this, right? So if you eat 2 slices of white bread and jam, so all refined carbohydrates for breakfast.
I think he means reducing calories without changing the percentage of fats, carbs, protein, etc. Yeah, but he can't possibly mean that because that would be so unbelievably retarded, right? 33% between every macro, fat, carb, protein, but in one world, the person eats 2,000 calories, and in another world, the person eats 4,000 calories. With the same percentage of macros, you think they both gain or lose the same amount of weight? No way, that would be such a stupid statement. There's no way he meant that, right?
And, there was a study in pediatrics, Dr. David Ludwig did this. He had people taking instant oatmeal, actually, which is a high glycemic index, and steel cut oatmeal, which is a medium glycemic index. So he gave these to the two groups would switch afterwards. So it's not the people. He gave them the same calories, same carbohydrates, in fact, the same food, even oatmeal, just differently processed so that they actually have different glycemic index. The glycemic index of the high glycemic index, instant oats, was like double that of the steel cut oats. Then he tested them and said, how much do you eat at the lunch afterwards? They ate like 30-40% more.
Right.
So the point is that you don't eat because of you're trying to fulfill a certain caloric quota or whatever. So it does come down to the calories you eat.
Is he going to say you eat because of how much insulin your body makes? That would just be so unbelievably naive, or like simplistic. I shouldn't say naive. That just sounds so simplistic. There's no way he's going to say that. He's going to say, spiking your insulin makes you eat more later on.
But what determines how many calories you eat? It's how hungry you are, right? So if you're
Okay, that's okay, sure, hungry you are. Although hunger, I think, is a confluence of several different, like leptin and heptin and peptin and meptin and cuctin.
eating certain foods that are going to leave you hungry, then you're going to eat more. And that's the whole point. If you're eating these high insulin foods, like refined carbohydrates, a lot of that's going to just get sucked into storage, which is going to leave you wanting more. So when you're talking about eating behavior, you're going to wind up naturally eating more calories. Yes, you can artificially try to, keep all the calories the same. And that's what they do in these metabolic wards. But that's not real life, right? It's like, I used to tell people, like, for decades, you got to count your calories and all this. It didn't help with, like, barely a single person. And I look at these studies, like the Women's Health Initiative, where they had, like, 300 calories less per day for, like, 7 years. And the difference between the usual diet and the low-fat, calorie-restricted diet, 300 calories per day for a year should equate to about 30 pounds less.
Well, that's not true, because as they lose weight, they will have a lower caloric requirement.
True, but the actual weight difference at the end of 7 years was like a quarter of a pound, right? Usual diet between, and these people are followed, right? They're not just like people are measuring what are you eating and trying to calculate how many calories you eat. They reduced 371 calories per day every day for 7 years. And by the end of that, they weighed a quarter of a pound. So somebody who followed their usual diet might weigh 200 pounds. A person who followed this calorie restricted diet weighed 190.
And was it 300 calories less than they were originally eating, or what?
Both groups actually dropped. So if you look at,
Where are the rest of our fact checks?
and that's probably just an effect of time. As they got older, both groups actually ate less. So, but
Oh, thank you. Okay. There's no shot this is true. Wait. Please. No way. Oh, God. It's only a minute. He's going to be like, oh, I checked this out, and it was actually totally true. My mind was blown. Fuck.
For Fact Check 2, Dr. Jason Fung here presents the Women's Health Initiative study and references that one of the groups followed a calorie restrictive diet, and that is absolutely false.
Got him. Never mind. Okay.
This was a randomized controlled study. The purpose of this was to check disease outcomes in the control group compared to the tested group. And the main intervention group was counseled to limit total fat to about 20% of energy, to increase the consumption of fruits, vegetables, and grains, while the control group just followed their usual diet. So they considered this a low-fat dietary intervention aimed at disease prevention, not a weight loss or calorie counting study. In fact, the authors were so clear about this. This is a quote directly from the research.
Oh, no. This guy's a doctor, right? Well, to be fair, clinical doctor, not a research doctor, okay? MD, loser, not a PhD, a GigaChad researcher. So you might not like to actually read full studies, okay? But Dr. Mike here has got us with the full study reading. Hell yeah.
The intervention was not designed for weight reduction or caloric restriction.
The number one thing when you actually get into reading research that's so frustrating is people who cite studies incorrectly, and then when you go and you read the study itself, the study will explicitly say, we do not want it to be cited in this way, and then people will still do it. There have been so many times on stream where we fact-checked like a fucking loser Peterson, Jordan Peterson, or like all these people who cite these studies, you go to read them, and they're like, actually, in case somebody cites it this way, like, this is exactly the opposite, or this is just not true at all, or we didn't measure this thing. It's so fucking annoying. This is like a crime against research. I hate it when people fucking do this. Oh my God.
So clear about this. This is a quote directly from the research. The intervention was not designed for weight reduction or caloric restriction, although body weight was measured and reported. So the fact that Dr. Jason Fung continually mentions this, not just in our conversation, but in other conversations he's had as a reason as to why calorie counting doesn't work, seems a little disingenuous, because that's not what this randomized controlled study was even looking at. The authors say it themselves.
Oof.
the difference between the two groups in the Women's Health Initiative, and that was published in JAMA in, I think, 2007. But either way, it's like, it's sort of,
I guess to simplify the question is, if you take someone who should be consuming, let's say 2,000 calories, if they cut out 300 calories, no matter what insulinogenic food or on the opposite end, a low glycemic index food that they eat, they will lose weight. Agreed?
300 calories per day? They didn't, though. Compared to the usual diet.
Like, so much of your model, like the question should be, okay, well, we need to have a conversation then about what are calories, or what is food, or what is the human body, or is this like the unexplained dark matter of the universe? How can somebody eat below their caloric consumption by 300 some calories and not be losing weight? What's going on here? Is there a metabolic disease or some sort of maladaptive metabolic adaptation or something that's happening here? Or what's going on that these people wouldn't be losing weight? Like, what is the model? This guy sounds like he's just selling some pseudoscientific like cure for diabetes, and it's all based, his pseudoscience cure is based around insulin or something. And for the rest of his life, he's going to peddle these same talking points because it's what he makes money doing. That's what it sounds like.
I'm not saying in that study. I'm saying if you calculate for a group of individuals what they're supposed to consume to keep their base metabolic weight or their base weight, let's say it's 2,000 calories, and you cut it down to 1,700, that group of people will lose weight. Or you disagree with that?
No, because all the studies show you lose weight for about 6 months, and then that weight always comes back up.
When you're still adhering to the diet?
Right?
Well, behaviorally.
Exactly. Yeah. So Dr. Mike brings up, well, if they start eating, maybe, but...
Not because
because
metabolically something's happening.
No, metabolically
Oh,
something.
cool. Yeah, so Dr. Mike's fixing on it. Yeah, so is there like a metabolic adaptation? Maladaptive? Would you call it maladaptive? Or would you just say a metabolic adaptation is happening? Something has to be happening
behaviorally.
here.
Yeah, I mean,
Not
it all
because
depends on the
metabolically
study.
something's happening.
No, metabolically something does happen. When you lose weight, the metabolic rate goes down, right? So
Sure, the
weight loss
metabolic
slows.
rate goes down 5 to 15% and usually is tied to how much weight also people are losing. So it's a pretty small factor.
No, actually, there's been multiple studies on this. So even in 1991, they did a big meta-analysis on this. They did 29 studies, and they looked at it, and they took all the studies about 10 to 20% reduction in calories. So 300 calories a day, sort of thing. And then when they looked at the metabolic rate, the reduction was about 10 to 20%. So if you're eating 10 to 20% less calories, but burning 10 to 20% less calories in response to that,
What? Is there another fact check on this?
well, you're not going to lose weight, right?
There is a meta-analysis. I feel like I would have heard about this. There is a meta-analysis that showed that cutting calories doesn't actually help you lose any weight. What?
Eating 10 20% less and burning 20% less.
Right, that's what makes it hard, but it doesn't mean that's a window you can't overcome. Because there's at some point where you, like if I cut down to 1,000 calories, my body's not going to cut down to 1,000
Oh no, I've seen
calories.
it. People have come to me and they.
Like if I cut down to 1,000 calories, my body's not going to cut down to 1,000
Oh no, I've seen
calories.
it. People
Did he say absolutely not, or did he say absolutely it will?
have come to me and they've done the studies and stuff. They wanted to. I have people who are like at 800 calories a day. They're barely burning any energy, and that's why they don't understand. I'm eating 1,200.
Oh, this is bullshit. This guy, fuck me and fuck you. And who linked this shit? Who said this guy was credible? This guy's just all fucking bullshit. Okay. This is just a pseudoscience, whatever, guru dude.
Calories. It's like your metabolic.
But
rate
energy-wise, how do you gain weight or not lose weight when you're
Yeah, what's happening to the energy?
under consuming that many calories? Because the amount of calories
it's-
out is
yeah.
not just your basal metabolic rate. That's important hugely, but it's also your NEAT.
Even your BMR. Could an adult male survive? Like, would 800 calories a day be enough to sustain an adult male? Weighs over 140, 150 pounds? Could you survive on 800 calories a day without losing weight? Is that even possible? Even with the most aggressive metabolic adaptation? I don't know. How many calories do comatose people burn?
Your exercise, the thermogenic effect of food. There's so many variables there that are
Yeah.
not being accounted for.
You shouldn't even bring any of this up. That doesn't even matter. 800 calories a day? I'm pretty sure my 65-year-old mom needs more than that.
Besides the metabolic rate.
Yeah, but if you look at the metabolic rate, so Rudy Leibel did that study where he sort of adjusted people, gave them a diet, made them gain weight, and looked at their metabolic rate and went up. And then when he made them lose weight, their metabolic rate went down. So it's clearly in response. So that metabolic rate,
Yeah, but your metabolic weight going up, oh my God, that's so horribly. Your metabolic rate will increase or decrease, but that doesn't mean that it decreases such that like if you cut 500 calories a day and you lose weight, your metabolic rate isn't going down because you're eating less. It's going down because you have less body to maintain. Now, there are exceptions for this. If you do like crazy crash diets, you can have permanent or almost permanent chronic metabolic adaptations that are bad. But like you're not burning less calories because you just happen to be eating less calories. It's because you're losing weight and your body needs less calories to survive.
if you don't look at anything other than calories, what happens, and virtually every study has shown this, that as you start to lose weight, your metabolic rate starts to come down, almost
He's not even disagreeing with this. Oh, he's about to say, though, almost about as much as you eat.
in lockstep, right? Even those biggest loser studies.
Well, the biggest loser stuff.
The Biggest Loser study is not at all analogous. That has to do with crash dieting, and the whole point of that study and how crazy it was that there were persistent metabolic adaptations to huge crash diets and then regaining weight, which was really bad. But the reason why those studies were so big is because it was an outlier from what we already knew. You would never use those studies as like your base mark for human dieting. I think maybe Dr. Mike's about to say this.
Loser studies.
Well, the biggest loser studies, even at the most they had someone's basal metabolic rate in extreme form, where they were on extreme starvation-esque
Yeah.
diets, extreme exercise.
Yes.
I think the highest that they had someone come down was 499 calories. And that's the most extreme case in the Biggest Loser study.
In the metabolic.
Yeah.
Oh, that's
So like
strange.
to
I
see,
actually didn't see that.
well, because if you factor in how many other things cause caloric burn throughout the day, the numbers are quite small. Even when we say like if you overeat, the body can regulate by burning more calories, like if you have a bigger meal, that's a pretty small margin.
It is. Your body, I think your body is generally, unfortunately, for us, I mean, fortunately for animals in the past, but unfortunately, I think your body's really good generally at holding on to calories. This idea that like, oh, well, if you eat a ton, they want to absorb, your body will fucking absorb everything you throw at it, okay? Bodies love calories, generally speaking, I believe. All right, fact check. Is he fact checking himself? Did he fuck up?
Dr. Fung, fact check number 3. This surrounds the issue of decreasing a resting metabolic rate
Oh, is he going to correct him on this? Because this whole thing was insane.
after significant weight loss or caloric restriction. So basically what happens to the body is if you start to significantly reduce the amount of calories you're taking in, the body has something known
Significantly. So I think 500 per day is considered like your upper threshold of healthy weight loss. I think it's like about a pound of fat per week.
as a metabolic adaptation, where it starts to decrease the amount of calories burned at rest. But now there's a lot of factors that go into that. Your body needs to burn calories in order to live. Think about that. There are other processes happening in your body outside of exercise all day long. That's the resting metabolic rate. But then you also have to factor in that when you cut calories and you lose weight, you become smaller. When you become smaller, your body requires less calories. Therefore, when we look at research when someone loses weight, we don't just look at the change of their resting metabolic rate, because that gives us a muddled picture. We need to figure out what their metabolic adaptation is. So we use this formula to calculate the metabolic adaptation. So throughout this conversation, and especially in this part, Dr. Fung and I go back and forth about how much of an impact does caloric restricting, cutting your calories, impact this metabolic adaptation. And in my research, for example, with the Extreme Minnesota Semi-Starvation Study or the Biggest Loser Study, the average metabolic adaptation.
There was a controversial Kyrgyzstan video from a couple months ago that talks about that study, I believe. The gist of it is that your body reduces energy expenditure to compensate for the reduced caloric intake. I don't believe that's the case. It's controversial and people get mad, but actually I think it has to do with your energy expenditure. I think your body, unless you're doing a crash diet or an extreme starvation thing, your body generally, I don't think adapts much to your caloric intake, but to your caloric expenditure, I think it adapts pretty well. Meaning somebody who exercises a ton, who has the exact same weight as somebody who doesn't exercise that much, burns about the same amount of calories, I believe, which I think that we haven't always thought, but now that seems to be like pretty, like even if you exercise a ton, your body will adapt such that you're burning about the same amount of calories as if you just sit on your couch all day. Either your BMR drops or you do less micro movements throughout the day or whatever, but more or less you just burn about the same amount of calories. And it reinforces the idea that caloric intake is really the only way, or the most important way, the best way that you can kind of modify your diet. Maybe not the only way, but like the most, I think, yeah.
Even in these very extreme diets, again, these are the most extreme diets, the metabolic adaptation was calculated to be about 499 calories. Yes, there were bigger drops of the resting metabolic rate, but then we have to factor in the fact that their bodies change. And when we factor in that body change, that's how we get to that 499 mark.
Unless you gain muscle weight, yeah, that's a myth that I've repeated a lot, but I don't even think that's true. Like if you take somebody who's 200 pounds at like 7% body fat versus somebody who's 200 pounds at like 40% body fat, I think they consume about the same, like BMR, their basal metabolic rate is about the same. Having way more muscle, I don't actually think burns that much more fat than just having like fat. I don't think the change is that significant, is my understanding. But somebody's got to study. Feel free to link it.
Factor in the fact that their bodies change. And when we factor in that body change, that's how we get to that 499 mark. When we look at general research, we see that this metabolic adaptation in terms of percentages looks exactly as I stated in our interview, between 5 and 15%. Most research seems to agree with that number. Dr. Fung presents this theory that if you cut calories by 10 to 20%, you will then in turn have a decrease in metabolic rate of 10 to 20%. So it's almost like you cut 10% of calories, your body burns 10% less calories. But this just isn't true based on what we've seen with a whole host of experiments. In fact, the research that Dr. Fung himself sent over to me and referenced in this interview from 1991, called The Physiological Responses to Slimming from the Proceedings of the Nutrition Society, said something very interesting in their overall conclusion. And I think this conclusion speaks directly to Dr. Fung's assertions here. They say that self-protecting physiologic responses to slimming are a very real phenomenon, meaning that the body does lower the metabolic rate when someone loses weight. That's a real phenomenon. I agree. Dr. Fung agrees. The paper agrees. Then they say, however, many people have acquired an exaggerated impression about them and believe that the body's defense mechanisms are virtually insurmountable barrier to successful weight loss.
Oh no.
It sounds a lot like what Dr. Fung is doing. Dr. Fung is saying if you cut by 10%, your body cuts by 10%, you're getting nowhere. So they're talking directly to this exaggerated impression about the body's defense mechanisms and that it's virtually insurmountable. And it goes to say, the present paper that Dr. Fung himself sent me and referenced in the interview, the present paper has illustrated that they are not so powerful as to be insurmountable. The sooner nutritionists remove this excuse from the range of demotivating myths concerning slimming, the more likely we are to effect successful long-term treatment, aka weight loss. Even in this study that Dr. Fung references and we read the conclusion of, they saw a typical average of a decrease in 10 to 15% of resting metabolic rate, which is around my 5 to 15% that I said. And they said only exceptionally severe or protracted dieting tended to push the suppression beyond 20 to
Like for the Biggest Loser study.
25%. And that's in line with what I said. Most people will have their metabolic rate drop by 5 to 15%. In very extreme cases, you can have it go more, but we shouldn't be talking about the extremes if we're talking about average weight loss. So all that goes to show that yes, when you start losing weight and you calorically restrict, there is a period and amount of metabolic adaptation that lasts years. The Biggest Loser study showed that, especially when there's a drastic amount of weight loss. That is true, Dr. Fung is right. But what Dr. Fung is missing here is that it doesn't necessarily act in such an insurmountable way that it completely negates any value of calorie restriction. That's an important takeaway. Because while the human body does try and self-regulate, it does a way better job at self-regulating by storing than it does by burning. Do you agree with that?
I think that the human body has to self-regulate the amount of body fat, because if you think about it, like the average person will gain about a pound a year.
I don't think the human body regulates body fat at all. The human body will hungrily grab onto any calorie it can and hold on to it. It doesn't feel good to burn calories. It doesn't feel good to be hungry. Like ultra calorically dense things taste good. Like this, I think your body doesn't, I don't even think your body has a mechanism to regulate body fat. I'm pretty sure left to its own devices, I mean, we've seen this, you'll be 500 pounds. Your body will get as fat as it wants.
Right, that's the average weight gain of an American and European. It's about a pound a year, right? So that's 3,500 calories. Most people are eating around 3,000 calories a day.
Is that really true? The average weight gain per year is 1 pound? I feel like it'd be higher. Or maybe it depends, I guess. Like, if you weighed 120 pounds, or let's say you weighed 140 when you were 20 years old, and then by the time you were 80, the fat person who's gaining a pound a year weighs from 140 to 200. That's a decent gain. But over a whole life, you're not 300 plus, 400 plus. I don't know. I feel like we're so overweight on average. There's no way that's the case. Average U.S. male weight, isn't it like over fucking 200 pounds? Oh, 199.8? Jesus. Yeah, there's no way that the average person well, maybe if you balance that out with women as well. But I don't know.
And European, it's about a pound a year, right? So that's 3,500 calories. Most people are eating around 3,000 calories a day. So your accuracy rate.
That might be true because of how large people are. But that's also significantly between men and women. I think you should be careful when you talk about weight stuff because men and women are going to be quite different here. But average daily caloric intake, American male, do you think it's 3,000 a day? Damn, that's a lot of calories, guys. The average American consumes more than 3,600 calories. Wait, is that true? What? What? No shot. Show me. I need to study. That's no way. That's insane. Jesus. I wonder. I don't know, man. Damn.
This is the whole population, most of whom are not counting their calories and most of whom's caloric variation is huge throughout day to day, right? Is like, 99.8% or something like that to consume 365 days of 3,000 calories. And then at the end of the year, only be off by 3,500 to have gained that 1 pound, with Christmas and, Thanksgiving, all in between means that your body has to be regulating how much body fat you have. That's why it's so difficult, right? Because if you try to now artificially turn that to lower your weight, your body's going to resist it by making you more hungry or reducing your metabolic rate. And the question is not then how do you adjust your calories, but how do you adjust that so that the body sort of adjusts your body fat to the correct
You're saying that we overeat so many calories but only put on a certain amount of weight?
Well, the average American gains a pound a year, which is 3,500 calories, roughly. A pound of fat is about 3,500 calories, right? So that means the average American or European has matched their caloric intake to their caloric expenditure to a sort of 99.8 or 9% accuracy rate without
that's-
counting their calories or knowing how many calories they're burning.
I mean, a big part of that is because, again, as they gain weight,
Don't you
their
drink
basal.
Don't you eat a hot chocolate and 2 cookies a day? That's like 1,000 calories, bro. First of all, my hot chocolates are probably around, if I get a big one, probably up to 400 calories. If I were to eat 2 cookies as well, you better believe I'm not eating lunch. What the fuck? If I had a hot chocolate and 2 cookies for breakfast, that means I'm only eating dinner, and probably not the biggest dinner. Plus the Red Bulls. Red Bull's probably 120, I think. 400 calories in a drink. Yo, dairy's big. Dairy's some big calories.
Metabolic rate goes up because they have more weight that they need to maintain. And as you store fat, you're also storing more lean muscle tissue so that you are burning more calories by being heavier, which is a concern of why if
How many calories is a Soylent? Soylent should be 400. How do you not get hungry though? I would feel like 2 cookies wouldn't satisfy me. I try not to eat 2 cookies. That's like a dessert day. That'd be a crazy.
everyone gets on GLP-1 medications, are we going to find a hugely sarcopenic population because they were overweight and having decent amount of muscle because they were overweight, but then once they lose the body fat, that they actually get exposed for not having enough muscle. So I think that is probably the higher likelihood of why people don't gain as much weight as they do per year, despite the caloric intake.
I think you know, to me, it's about both the calories, but also about the insulin, not just insulin, but the sort of hormonal effects of the foods that we eat. Because to me, I see food as containing two things, right? It contains the energy, which is the calories, and it contains certain information. So you eat a food, your body reacts to it by producing hormones, which then translate what you're telling your body. So if you eat a food and you produce a lot of insulin, your body is going to respond differently than if you eat lean chicken breast. So you eat cookies, for example, your insulin's going to spike way up. You eat chicken breast, same calories. Your insulin not going to spike up. Your GLP-1 will spike up because the protein actually tends to raise GLP-1. Or you eat a really high fiber, lentils or something like that, right? All that fiber gets into your colon, which produces, short chain fatty acids, which stimulates GLP-1. So you eat all that fiber, you got stretch receptors, you got GLP-1s, you're going to be full. So those two are very different to me. So all I'm saying is that you have to account for the hormonal effects of the food, which means that some foods are more fattening than other foods, right? Which to me doesn't seem like a huge leap, but that's.
I just think the vocabulary, it's not that they're more fattening, so they cause you to eat more or eat less, kind of, right? Which is true. I think that's a good way to view it. Like, not all food is necessarily the same in terms of the impact it'll have on you, but
that's really all I'm saying. Like, you have to consider more than just the calories, because the foods affect the hormones, the insulins, the GLP-1s, the stretch receptors in our stomach, the peptide YY, all of those things.
For sure. Yeah, I think the idea that certain macronutrients of food play a role in behavior and how the body behaves, I don't think is disagreed upon by people in the nutrition space. I think it's widely, in fact, celebrated to incorporate lean cuts of protein, that the villainization of fat was kind of a really big mistake that we made, because there's actually very healthy fats that can contribute to a healthy metabolic profile, that can contribute to weight loss, that can contribute to satiety. And that refined carbohydrates is probably the main reason why our American standard diet is so terrible. We frequently, especially on podcasts, get into the situation of nitpicking a specific chemical, saying, oh, high fructose corn syrup, that's the thing. If we only replace it with cane sugar, we'll fix all our problems. No, we're not.
That's not much of a difference.
Yeah, exactly. That's in those situations, I think we're getting more into the headlines as opposed to the practical implications. So I don't think most people would disagree on that.
Well, I hope so, because to me, I think both things are very important, right? So 100 calories of lean protein is different than 100 calories of refined carbohydrates. Like, to me, that's just obvious. But I don't know. A lot of people come at me and they go, a calorie, it's all calories.
how many people, such like random gym bros online, say that? I feel like even over half of gym bros these days would acknowledge that. Like, who is ever saying that? Like, if you eat 100 calories of Oreos versus 100 calories of chicken breast, you're going to feel the same satiation afterwards. Like, I feel like this guy does battle. He must be like a fucking, not even a 4chan, because even the fit boards on 4chan will be this stupid. Who's this guy arguing with? Who is this guy arguing with?
Like, to me, that's just obvious. But I don't know. A lot of people come at me and they go, a calorie, it's all calories. It's like, it's all the insulin fairy. Like, it's like, no, well, because it has a physiologic role. That's all I'm saying, right?
I think it's just a situation of talking about, again, the nomenclature, the words of it all. Because if you really look at it, and again, I think you'll agree with this, for me, it's very obvious if I consume 4,000 calories, I'll gain weight. If I eat 4,000 calories...
He doesn't even agree with that statement, though, I guess.
...of Oreos or 4,000 calories of beef, I'm gaining weight. And I think that's a starting point.
He doesn't even agree with that. Jesus.
We have to agree on before we move on.
Yes, we'll agree on that.
To varying degrees.
But they've done those studies, right? And the thing is that you will gain.
I can't...
Wait, yes. Yeah. But then when you stop the study, what happens is that your weight just goes right back down, right?
Wait, what did he just say? You'll gain the weight, but when you stop the study, the gain weight. How do you know? Wait, what? What is he saying? It's like the best track on this CD is like track 13. And it's like, bro, there's only 12 songs on here. Oh, yeah. But when they stop recording, oh my God, bro, they just fucking kill it in that studio. How do you know?
Yes. But then when you stop the study, what happens is that your weight just goes right back down, right? And then
he's got to be thinking in his head, what? What am I supposed to say to that? What?
they did these studies.
What do you mean goes right back
So Ethan Sims did these studies in the 1960s, and another researcher. I can't remember
You're saying
his
it's
name.
not lasting weight gain if I get it through protein?
Yeah, so Ethan, do you remember this? So Ethan Sims in the 1960s.
I mean, we're going way back.
Yeah. So this is very interesting because he was trying to get mice to gain weight, and he couldn't do it. The mice would eat a certain amount and stop, and they wouldn't go and become obese. So he thought, okay, well, this is very strange. So then he got college students. So he went to Vermont College, and he got college students and said, I'm going to do a study. You're going to come, you're going to eat, and you're going to gain weight, right? That's all I want you to do. And they're like, no problem, right? I'll just eat, right? They couldn't do it. They couldn't eat too much and gain weight. They couldn't gain weight. So he said, okay, well, maybe because they're exercising more or something. So then he went to the prison. This is before they had like ethical reasons. You can never do this now. So he got these prisoners and he basically forced them to eat and restricted their exercise. And it turns out that he did eventually get them to gain about some weight, 10 to 25%. But they had to eat like 8 to 10,000 calories to do that.
What? Why does Dr. Mike talk to these people? I'm glad he does the fact check thing. This must be the next fact check, right? Okay. What?
Bodies were fighting at every step
He's got to be wondering, what are we talking about here? What?
of the way. So he got them to gain the weight. Like, it's a lot harder than people thought.
What was he feeding these prisoners? Were these like prison torture chambers? Welcome to your 6th huge dinner. Yes, honey. I'm ready for my 10,000 calorie daily diet.
He was actually stunned. And then at the end of the study, he said, okay,
Also, huge red flag. There are certain topics that we study a lot. Diet and nutrition and hormone profile, especially in the age of Ozempic and even before that with diabetes and everything else. When somebody has to go to 1960 to give you a study related to weight loss or weight gain, that should be a massive red flag. Like, oh, back when we used to study weight loss and weight gain, back in the 1960s, but I guess we don't give a fuck about that anymore. There are no new studies on that. What is he even talking about?
okay, fine, you're done. Just eat whatever you want. Their weight actually fell right back down within like 2 months. They went back down to their normal weight with weren't trying to lose weight. They just stopped eating. So there's not.
Like, what does that mean? They weren't trying to lose weight. They just stopped eating. Yeah, you're going to...
Natural mechanisms to do that, right? So it will gain in the short term, but what happens in the long term in those studies?
What's your takeaway from that research?
Okay, fact check number 4. Thank you. Jesus Christ. He's going to say, I bet the study just doesn't exist. 10,000 calories a day? Even 8,000 calories a day.
Fact check number 4 with Dr. Fung. Here he's talking about the prison experiment where prisoners were force-fed a huge sum of calories and ended up gaining weight, and then were allowed to return to their normal diet and ended up losing the weight. And so
Oh, okay. 8,000? 10,000 calories a day? No shot. But also, yeah, wait, there's nothing surprising about this. If you were force-fed a fuck ton of calories, like past the point where you'd even want to eat them, and then you stop eating that much food, of course your weight's going to go down. No shit.
somehow he connects that to protein consumption. So to me, this is very messy and it warrants an explanation. In this very unethical Vermont prison experiment where they were overfed, yes, when you drastically overfeed a population to the tune of 10,000 calories for a short period of time and cause them to gain weight, and then return them back to their normal diets, they will lose weight.
Of course.
And they will largely not have huge issues with that because their amount of weight gain, meaning the time that they gained the weight, wasn't significant enough to cause drastic hormonal changes, epigenetic changes. These are changes that happen to someone who's gaining excess weight year after year after year, and even more so if they were carrying that excess weight from adolescence, from earlier stages in their life. So showing that those prisoners went back to their normal weights after being force-fed an extreme diet doesn't tell me, A, anything about protein, because that's what he's referencing here, and it certainly doesn't tell me any valuable takeaways other than if you force-feed someone an enormous amount of food and then you allow them to eat a normal amount of food, they will lose weight. That's pretty expected, I think, no?
The pain associated with acute overeating, so overeating in a short period of time, is illustrated by the first-hand experience of the author. The rapid return to normal weight contrasts with the difficulty that almost all people with obesity experience when they attempt to lose and maintain weight loss, contrasting the response to overfeeding of individuals who are resistant to obesity with those who are obesity-prone, provide an avenue for unraveling the difficulties people with obesity face when trying to lose weight. How much was he feeding these people? Wait. Is it this one? Experimental obesity in man. Jesus Christ. No abstract available. Is there, if I sci-hub like the link to that, will I find anything? Okay.
Search. I think it's that your body has a natural set weight, which is sort of determined, and you can artificially push it up, but your body will eventually lower it down. So we know that, for example.
Eventually, based on what timeline or?
So in those studies, it was like 2 months. So we know a lot about.
I mean, if that's the case, why are we just exponentially going up with our obesity?
Yeah, it's a good question, right? Because I think that what happens is that in those situations where they artificially made them gain weight, so those people, their fat cells expanded, right? They gain weight. They're eating with 8 to 10,000 calories. Their fat cells then produce leptin. Leptin causes anorexia. They stopped eating. So then they lost all that weight. So there's hormones that will push your body weight upwards, like insulin. You give somebody insulin, they gain weight. And there's hormones that will push it back down. So leptin did in that case. Obesity mostly is a leptin resistant state, but GLP-1 also pushes it down. So I think the point is that the changes in the diet, in the American diet from like 1977, where it started to spike up to, today, there's been such a change in the diet that has gradually been pushing it up. And a lot of it, I think, has to do with the processing of foods, which tends to make foods like
Produce more insulin?
a lot, like it sort of hijacks the brain, right? So if you eat natural foods,
Because I feel like he does a lot of things that are like kind of true, but then he just goes crazy.
it's very hard to overeat those foods. Why? Because we have natural satiety hormones, because it all comes down to hormones. So you eat, for example, beef or steak or chicken. You eat that. Well, can you keep eating it until you explode? No. There are restaurants that will give you a free steak if you do that, right? No, but they're not giving away a lot of free steak. Why? Because the peptide YY goes up, the cholecystokinin goes up, and these satiety, the GLP-1 goes up. These satiety hormones are so powerful that they basically stop you from eating. So just like if you eat a pork chop at a big buffet, then you're so stuffed and somebody says, here, have this pork chop. You're like, oh, I'm going to throw up, right? It's the same pork chop. But the difference is that your hormones are, on full satiety. The difference with ultra-processed foods is that you're taking away all those satiety signals. You change them into ultra-refined carbohydrates. So there's no protein, there's no fat, so there's no peptide YY, there's no cholecystokinin. If you eat a bulky meal, like lentils or something, or beans, well, your stomach fills up, right? And your stomach stretch receptor sends through the vagus nerves, tells you stop eating, just like if you have a bezoar or something, right? You have to stop eating. So big volume, high fiber foods are going to do that. Other foods like the GLP-1s are going to slow down your gastric emptying rate. We know that. So you eat lots of protein, gastric emptying rate is going to slow down. Fiber, it gets fermented in the gut, becomes short-chain fatty acids. GLP-1 goes up, slows down the movement of the gut, right? So if you're slowing down the gastric emptying rate, stomach stays full longer, you're activating those stretch receptors. So natural foods is very hard to overeat because you have protective mechanisms against that exact thing. Because you have to, people always say, okay, body fat, we're designed to store fat. And now that calories are easy, we must gain fat. No, that's absolutely not true because no wild animal becomes obese. Why? Because if you're fat, you can't catch food and you can't run away from predators.
What is he? Like what? Yeah, no shit. That's what people mean. But we don't have to run around and hunt for food. This guy, oh my God.
Fat. We're designed to store fat, and now that calories are easy, we must gain fat. No.
People are trying to say humans are gaining fat just because calories are easy. Well, what about deer? What about animals that have to run and hunt for food? Okay, how about you look at house pets that can easily become overweight if you overfeed them? Wouldn't that be the analog here? Not things that still exist in nature that have to hunt for food.
That's absolutely not true because no wild animal becomes obese. Why? Because
this is this is a meme point. This is like a troll. This is a troll argument.
If you're fat, you can't catch food and you can't.
Like you think humans on modern diets automatically become fat? Well, let me introduce you to this like remote island tribe that still hunts and doesn't have access to clean water or electricity. Like these people aren't gaining fat. So tell me what's going on there, buddy.
Not true because no wild animal becomes obese. Why? Because if you're fat, you can't catch food and you can't run away from predators. You're going to die if you've got too much body fat. So body fat is regulated. Eating behavior is regulated.
Well, I mean, it's hard to relate us to other species because if you're hunting for your food and you're obese and you can't run to catch your meal, you're no longer going to be fat. So that's a self-fixing problem there. But I think
you might get caught.
Yeah.
But anyway.
But the point I want to point out with this whole situation, because I think I agree with you in totality.
Okay. Watch the rest of this tomorrow. Jesus fucking Christ. How many fact checks are left in the description for the 1+ hours remaining? Just one.